the fluid within the eye, not the eye wall itself. Another useful classification for high myopia, which mainly done by Dr. Tokoro in 1988, he tried to classify the macular changes that are seen in highly myopic eyes, and we'll come across that later on. So this is the main topic of the presentation, what we have learned or what we couldn't see before the advent of multimodal imaging. Before going to that, I'll share with you my preferred technique or imaging protocol for patients with for highly myopic patients. I prefer to do a line scan for all of these cases, especially horizontal and vertical. And I'll expand on that later on. And I like to prefer to do a 3D cube, and when possible, I'll do a cross scan. And for all my high myopic patients, I do disc scan, and I also sometimes do an extra scan if there is an area of pathology. For example, if I suspect a CNV, I may do further an OCT angiography. I generally prefer swept source OCT when I image highly myopic patients. It has some advantages, particularly in high myopia. One important thing is that it's very quick, and the other thing is that it provides us with a wide scan range, so we can image the area of the staphyloma and as well as the area beyond the staphyloma. However, the main advantage of the swept source is that it uses long wavelengths, so it has a deeper penetration. So if we are planning to look at the deeper layers of the eye, like the choroid or the sclera, it has some potential advantages for that. And another advantage is less affected by media opacities like cataracts or hemorrhage and so on. One useful tip when we image patients with staphyloma is that the lateral scanning range is often wider than what we're checking on the machines. For example, if we select a 6mm scan, this is usually ends up 7mm, and this is because the eye axial elongation of the eye. We also, when we image highly myopic patients, we come across what we call image inversion or mirror artifact. And actually some softwares can correct that. And this is usually because the presence of the staphyloma, which is beyond the scan range. Also, because there is axial elongation of the globe, we usually see image degradation when we came away from the zero level. So if we want to scan this area and we put the zero level of the machine at this point, the image will degrade as we go away from the 0 points. You can see here the image is degraded here and here on the sides. So it's very useful when you scan these patients. If you are looking for the macula, try as much as you can to make the 0 level or the focus on the fovea. So this is our main presentation, and I have grouped what we have learned into 10 main findings or 10 main pathological changes. This is an example of a patient I came across. It's a middle-aged patient, 6/12 vision. Interestingly, because the highly myopic eyes, the fundus is tessellated, you can hardly pick up any pathological change. But with OCT, we can find that this patient actually has many changes. You can see there is an inner schisis, and there is also outer schisis. And this change is very common with myopic foveoschisis. Is what we call columnar-like structures, often seen at the level of the outer plexiform layer. And sometimes this can be associated with other changes, like in this case, foveal detachment. Why this happens? As you know, in most of these patients, there is an axial stretch of the globe. And we know that some layers are inelastic compared to other layers. So the inner retina is less expansile compared to the other ocular layers. And interestingly, in these cases, we hardly see any changes if we do fluorescein angiography or ICG. And as you can see in this picture, you can see here, we are actually imaging the area of the staphyloma. So you can see the area of the staphyloma, the eye expanded in this area, but the inner retina is non-expansile compared to the outer layers of the eye. That's why we get this stretch. Therefore, I feel it's essential to do OCT for all patients with highly myopic eyes, especially if they have any visual symptoms. Another patient, you can see within the staphyloma, we can see an area of foveoschisis. And actually, foveoschisis is one of the most common complications, especially if we look for it. We can see it associated sometimes with epiretinal membrane. Sometimes we see with foveal detachment. Sometimes we see some lamellar defects as well. And sometimes we see a hole and macular detachment. This is simply because this layer can't expand like the outer layers of the eye, so that has led to focal detachment. And there's usually a tiny defect, as you can see here in the yellow arrow. The second change we sometimes see in highly myopic patient is this peripapillary change. Many years ago, that was thought to be a pigment epithelial detachment. However, with the advent of OCT, it took the nomenclature of peripapillary intrachoroidal cavitation. And this cavitation, it's actually very common if we look for it. It's present in about 5 to 10% of myopic eyes, more than 8 diopters. And it's usually like a cavity. We can see here in the picture, this yellowish orange change is like a cavity around the optic nerve. And in some selective cases, like in this case, it's connected to the vitreous cavity. The cause of the fluid within the cavitation is unknown, but it's thought to be coming from the vitreous by one way or another. Clinically, as you all know, analyzing the optic nerve in highly myopic eyes is often challenging. And with the presence of peripapillary intrachoroidal cavitations, we occasionally see visual field defects that could mimic glaucomatous changes. So we can keep that in mind when we checking these cases. Dr. Spade tried to look exactly why this happens. And it is thought that this area around the nerve is where the defect occurs. And this area is called the border tissue of Jacobi. This is the area where the cavitation occurs. Using the multimodal imaging, we can also highlight this cavitation without OCT, but as you know, OCT is the most useful for the picking up these changes. In fluorescein angiography, we often see early hypofluorescence, and sometimes we see late staining, but no dye pooling. So the third change we'll talk about is very similar, is what we call macular intrachoroidal cavitation. That was highlighted by Dr. Ono Matsui. Dr. Ono is one of the pioneers in high myopia worldwide. She gave this change the definition of macular intrachoroidal cavitation. And you can see here in this picture, there is an area of focal atrophy, and you can see there is something like a cavitation within the choroid. You can see the choroid here is very thin, like in high myopia, but here is relatively like a cavity-like structure. And this cavitation is very different from patchy atrophy. As you know, in patchy atrophy, we can see here the retina is thin and atrophied, and we don't see any change across the scleral border. But in the macular cavitation, we can see some posterior pawing of the sclera, and we can see this cavity change. And the choroid in the macular intrachoroidal cavitation area appears to be thickened, and the retina appears to be caved into the cavitation. It's thought to be that there is a direct communication between the vitreous and the intrachoroidal cavitation in some eyes, very similar to the peripapillary change. Occasionally, we may see adjacent retinoschisis, and sometimes clinically, it may mimic, at least clinically or sometimes in 3D OCT scans, what we call pseudofovea. The fourth change is Lacquer cracks, and actually Lacquer cracks were identified many years ago, and it's a fundus picture change. But with OCT, we learned that Lacquer cracks are mainly RBE disruption or attenuation, affecting mainly the areas of the Brooks membrane or the choriocapillaris. And this is an important change, because sometimes we see some pathological changes or vision-threatening complication associated with Lacquer cracks, like simple retinal hemorrhage, or in a small proportion may develop myopic CNV, or some patients may develop patchy atrophy, which later on has a potential risk to develop myopic CNV. In a study by Dr. Liu and colleagues, they found that the near-infrared reflectance and ICG have the high sensitivity to detect Lacquer cracks. As you all know, we can see them clinically in color picture, but sometimes the early lesions may be difficult to pick up. Based on this study, the near-infrared reflectance and the ICG have the high sensitivity to pick the Lacquer cracks. And this is actually logic, because these use long wavelengths, so they can image deeper structures within the eye. The fifth change is myopic CNV, which are we all familiar with. So I'll just speak quickly about it. It's in about 4 to 10% in highly myopic eyes. It's often seen in areas adjacent to Lacquer cracks or patchy atrophy. As you all know, we often diagnose that with fluorescein angiography, or recently with OCT angiography. In highly myopic eyes, it's usually type 2 CNV, I mean subretinal CNV in most cases. And we can easily depict that with OCT angiography or fluorescein angiography. However, in clinical practice, sometimes it's very difficult to differentiate between myopic CNV with simple hemorrhage, or just a simple hemorrhage. As you know, like in these two cases, sometimes we see this hemorrhage within the fovea, which could be due to just a simple hemorrhage associated with Lacquer cracks, or could be a hemorrhage originating from the CNV. We can use the clinical modalities, the multimodal imaging, to differentiate between these two conditions. And I found this table is very useful. Like in myopic CNV, you usually see a little bit of leak. Sometimes you see like a hyper-reflective material, or sometimes with OCT angiography, you can pick up some flow. Compared to just only a simple hemorrhage, you don't see many of these changes. However, even with that, sometimes it's very difficult to differentiate the two conditions, especially in very early cases of CNV. And my feeling, the best thing to do is to repeat the scans later on after 2 to 3 weeks. The theory behind that, if it's a simple hemorrhage, usually it will just get less in size and improve a little bit. But if it's a CNV, you may see worsening of the amount of the fluid or the exudative changes. Yeah, Dr. Adel, is all okay? Can you hear me?
Yes, it's quite clear.
Everything going well, yes. Is there any question from the audience? Or?
We do have some questions, but we'd rather address them at the end, if it's okay with you.
Okay, fantastic. So everything is going well. Okay, brilliant. So 6 is dome-shaped macula, and this is actually a very interesting change that was recently identified in high myopia. Dome-shaped macula was originally picked up in OCT and B-scan. It's a very interesting change. And as you know, in highly myopic eyes, in normal eyes, we see this curvature of the posterior bole. In highly myopic eyes, we expect them to have this steep curvature. But interestingly, in eyes with dome-shaped macula, they found to have like a little bit of a bulge within the macular area. As I mentioned earlier, it's very useful for highly myopic eyes to do a vertical OCT scan. For example, like in this case, if you do a horizontal scan, you will hardly pick up any change. But if you do a vertical OCT scan, you'll see this bulge, or what we call dome-shaped macula. We did some work previously on dome-shaped macula, and we put like a definition for it. If dome-shaped macula is diagnosed when we see this macular bulge more than 50 micron. And we tried to do 3D imaging of the macula using wide scans and then transfer that to a 3D image reconstruction. And interestingly, we found an interesting finding that in this picture, if we segment the RBE layer of the retina, we can depict the shape of the posterior bole. So this 3D reconstruction is reconstruction of the shape of the posterior bole using RPE slab. And interestingly, in these cases, we found that most of them, they have like a band-shaped ridge within the macula associated with a superior concavity and inferior concavity. That's why when we do a horizontal OCT scan, we see little or no change in the curvature of the posterior bole. But when we do a vertical OCT scan, we see this dome-shaped like configuration. So we term it that as a band-shaped ridge. So about 80% of people having this dome-shaped configuration, it's actually a band rather than a dome. And there are this ridge in the center and superior and inferior concavity within the posterior staphyloma. And the remaining about 20%, they have a very typical dome-shaped bulge, like what we were expecting. If they have this bulge, if we do a vertical and a horizontal OCT scan, like in this picture, we'll see a bulge within the macula. And this type, or the typical dome-shaped bulge, is actually only 20% of this cohort. Dome-shaped macula is an important clinical entity because about 60% of these cases, they have vision-threatening complication. And there is a wide range of these changes. The most important for us is definitely the presence of CNV, but it can also be associated with serous detachment, also lamellar holes. Interestingly, in eyes with dome-shaped maculopathy, we found that extrafoveal schisis is very common, but foveal schisis is very uncommon. And you can see here, only 1% of eyes has foveal schisis, but nearly 15 or 17% of eyes has extramacular schisis. This finding is really interesting. It seems like in this picture, the presence of this dome-shaped bulge may act like a macular buckle or an indent. So there's no schitic changes here in the center, but away from the center, you can see the schisis. Very similar, like a macular buckle or an endoplomb. And then we asked ourselves, what happens if we monitor these cases for 1 or 2 or 3 years? So we did another study checking the 2 years changes in the sclera and choroid in patients with dome-shaped macula. So this patient seen in 2011 and then monitored till 2014, you can see some progression of the atrophic changes along the staphyloma in the posterior bole in this picture compared to the baseline check. And this is 3 OCT scans, vertical OCT scans. They are all centered at the main line, and with careful interpretation of the image, we notice that this is the bulge of the macula. You can see the bulge has increased over time. So the bulge was initially 262 micron, and after 2.5 years increased to 300 micron, 326. So the first change here over time is the increase in the scleral bulge. Another way of analysis, if you draw another line here, this line is tangent to the RBE line. This line is at the edge of the bulge. If you look carefully over time, you can see this area appears here over time. This means that there is some deepening of the concavities over time. So the eye has elongated, but there is some sort of asymmetric expansion of the globe. So let's take another case. You can see in this case, the macular bulge was 151. Here the macular bulge was 171. And this is nearly over a 2-year period. You can see here the images are adjusted, so exactly the same location. And you can easily do that by looking at the areas of the blood vessels. So to make sure that you are measuring the same location. And we can see the bulge has increased by nearly 20 micron over 20 years. With this way, if you look at imaging of the sclera at multiple points, you can even make a scleral thickness map. So this is a scleral thickness map, and this is showing the change. And we analyzed these eyes, and we found that over 2-year period, the scleral thinning was asymmetric, and there was a greater thinning in the superior and inferior and temporal regions compared to the subfoveal and nasal region. So, in simple words, the scleral thinning was much more obvious in the superior and inferior areas and temporally compared to nasal and the subfoveal. So over 2 years period, there are nearly 20 micron less scleral thickness in this area, but it was preserved along the fovea and the nasal side. We speculated that the relatively preserved sclera at the fovea and the nasal side may act like a macular pillar to support the expanding globe. So we'll go ahead to the 7th change, and I'll share with you this picture. This is a highly myopic patient, and when looking at the fundus, you can hardly pick up any change. But careful looking at the blood vessels here, you can see some changes along the blood vessels. This is what we call paravascular anal retinal defects. And we studied that previously with my colleagues, and we found that these paravascular anal retinal defects are associated with some retinal nerve fiber layer thinning. They also can cause visual field defects like relative scotomas and nasal steps in some cases, which are very difficult to distinguish between glaucoma. And this change is mainly due to the difference in elasticity of the ocular layers. It seems like the anal retina is less elastic compared to the outer ocular layers. And it's a very similar change which you may come across during some surgery for highly myopic patients. Like in these cases, we can see very obvious paravascular anal retinal defects, like in this case. There are also some many types of paravascular changes we can see in highly myopic patients, like what we call cystoid changes, which are commonly seen around the blood vessels. It's like cystic-like degeneration, and it's mainly because the blood vessels are not stretchable compared to the retinal tissue. So they cause a little bit of traction, and this causes some schitic changes or paravascular cystoid changes around the blood vessels. And sometimes we see these folds again, simply because the eyes, the blood vessels can't stretch compared to the ocular layers. Another change is just symbol defects around the blood vessels, which are very common, especially in high axial lenses or very highly myopic eyes. Another interesting finding we may see in highly myopic eyes is what we call tractional internal limiting membrane detachment. And in this change, we see the ILM is separated from the nerve fiber layer. There is, can see here, there is an inner retinal schisis and outer retinal schisis. And this is the internal limiting membrane. And this is some schisis at the area of the retinal nerve fiber layer. So we often see this change alongside cases with foveoschisis or macular schisis. And sometimes it's tricky to differentiate these changes from whether it's an epiretinal membrane or just simply an ILM detachment. And I'll share that with the audience. So at the end, I'll be grateful if you can tell me, what do you think? Is this an epiretinal membrane or just an ILM detachment? Another finding, which is what we are all expecting, that there are thinning of the all ocular layers. There is a thinning of the retina, but there is also a thinning of the choroid and sclera. And we can see that in nearly all myopic eyes. You can see that there's some choroidal thinning, which is correlated proportionally with changes in the axial lens, or if there is a staphyloma, or if there is a chorioretinal atrophy. And there are some studies estimated that the rate of the choroidal thinning over time, which roughly varies according to the age. Over time, as the eye elongates, and so the choroid becomes extremely thin, and even the sclera becomes much thinner, we can see not only thinning, but we can see some deformation of the shape of the posterior bule. You can see here very thin sclera. Even we can see the retro-ocular tissue. So the number 10 is the retro-ocular imaging. With the advent of OCT, especially the swept source, we can even analyze the retro-ocular tissue. So this is the retina, this is a very thin choroid, this is the sclera, but this is the retro-ocular tissue. And we can see the layers behind the eye, including even the retroorbital fat. Also, one change, if we analyze the images, this is thought to be like a perforating scleral vessel. Another case of a perforating scleral vessel, and these usually show well if the scans come across the area where the vessel perforated the sclera. That's why it's useful when imaging these eyes is to do multiple cross scans, vertical and horizontal, to look for these changes. In very advanced cases, sometimes we see what we call very thin sclera or transparent sclera. Like in this condition, even we can see the retroocular tissue, because the sclera is very thin, so it becomes transparent. And we can see there is significant dissociation of the scleral lamellae, especially at the borders of the staphyloma. Also, like in this case, we can see very thin retina. And I'll share with the audience, what do you think this structure could be? I'll answer this one.
Okay.
Okay. So, yeah. So, this is thought to be the inferior oblique muscle aponeurosis. If you look at the back of the eye from behind, this is the nerve. And if you take this cross line, like here, you can see this is most likely to be the inferior oblique aponeurosis. So in summary, the multimodal imaging has helped us to pick up many changes, like the Foveoschisis, peripapillary cavitation, or macular cavitation. Lacquer cracks, we are able to image them. We used to see them in color picture, but now we can analyze them carefully with multimodal imaging tools. Myopic CNV, very interesting change, is dome-shaped macula. We came across many paravascular changes, and I hope that after this presentation, you start to look for these changes. You'll find them much more common than what we thought before. Also, we talked quickly about the Tractional ILM detachment. Also, scleral and choroidal thinning, which is something we were expecting to see when we image these cases. And also in some selective patients with very high myopia, we can image the retroocular tissue. Okay. Again, high myopia is a condition that affects all layers of the eye. It's a pathological change. It's not only one layer, but all layers are involved. And when you come across these patients, again, don't forget to check the disc carefully as well as the periphery, because there are many peripheral retinal changes. And we all know there's a link with the changes to retinal detachment. I'll acknowledge the help of my colleagues, and thank you very much.
Thank you very much, Dr. Abdullah, for this very informative presentation. I think you've covered a lot of parts of the myopia, and it's really a mystery when we think about myopia. How does it? Why is it happening? Why is it progressing? How we can stop it? It's one of the things that we face a lot in our practice, and hope that we have a lot of any tools to help our patients. But I think this is one of the diseases that remains a mystery.
Sorry.
I would like to remind everyone that the floor is open for any questions. And if you have a very burning question, you can raise your hand and join us. I think just to bring a very important tool that we have is the OCT. And you mentioned that you're a big fan of swept sort OCT. I'm sure because of the deeper penetration, you can see more of the choroid and even the sclera in those cases.
Yeah,
but
actually, even with the usual spectral domain OCT, you can get very useful pictures. But again, there are some potential advantages for the swept source OCT. It's mainly because the long wavelengths used, so you can image the deeper structures of the eye. It penetrates better. However, even if you do the use the usual one, you can do enhanced depth imaging. But still, I feel the swept source is a little bit quicker and easy to capture the images.
I think Dr. Asarsa Nwelati is commenting. She was saying that there is also patchy atrophy, generalized atrophy, macular holes. These are all things that can also be associated with this condition. I want to ask you about the OCTA. We generally are very excited about this technology.
Yeah.
But there are we still are trying to discover the values of what we can really learn from this imaging mode, and I think one very valuable tool is in our condition is CMVM in myopic patients.
Yes.
What are the things that you would look for in an OCTA in this situation?
Yeah, thank you. That's a really important question. I do OCTA for almost all patients, highly myopic eyes, especially if I suspect any presence of CNV or the patient coming with a blurring of vision. In most cases, you can pick up the vascular network, at least a part of it. Sometimes you can also look for the flow. But as you know, there's many segmentation errors within the OCT angiography. And the most common clinical dilemma is when you see a patient with a tiny hemorrhage and you are not sure whether this is just a simple bleed from a lacquer crack, which is a very common actually, by the way, or a bleed associated with a CNV, especially when you see like a tiny hyperreflective change alongside the RBE. Oh, could it be just the hemorrhage? Could it be just a CNV with the hemorrhage? And in most cases with OCT and OCT angiography, in addition to fluorescein angiography, you can make the diagnosis, but in a small proportion of cases, it's very difficult to make the diagnosis. And in this cohort of patients, I usually repeat the scan in 2 or 3 weeks later, or even 4 weeks later. The theory is that if it's a CNV, it may will be leak more, or you see more exudative changes. If it's just a simple hemorrhage, it will clears up to some extent. But with the advent of OCTA, I think we'll be able to at least make a differentiation based on OCTA.
A question of how would you differentiate between myopic stretch lines and lacquer crack? And is there a clinical significance to differentiate between them?
Again, as retina specialists, we look for the pathological changes. Our main concern is what affects the vision, okay? And lacquer cracks were identified many years ago. And you can see them simply as shown in the picture. I think in one of these slides, just some destruction at the level of the RBE. But again, lacquer cracks alone are not a problem because you will see them in many patients with highly myopic patients. But they are a concern if they started to develop other complications. So the main motive is the vision-threatening complication. Should go to the slide with the lacquer cracks. Yeah. Oh, sorry. Yeah. For example, this patient has this lacquer crack uprising network. This patient has more. But as long as they don't have vision-threatening complications, that's fine, and we are only monitoring them.
A question about the. I know you've done a lot of work on dome-shaped macula, and this is one of the conditions that's really interesting, and the way it's. I don't know if it's a blessing or a curse for those patients. But one of the complications is the subretinal fluid that you get with those cases.
Yes.
I know that you've studied this a lot. What do you think is the reason for this subretinal fluid that develops in those patients?
There are two conditions actually which are maybe mimic each other. One is dome-shaped macula, and the second is eyes with inferior posterior staphyloma. These conditions you may find a small cuff of subretinal fluid within the macula. The cause for that is unknown. There are some speculation due to some constriction of the choroid or some disturbance in the choroidal circulation. There are some speculation because due to changes in the choroidal thickness. My feeling is that this is more or less a structural change related to the asymmetric expansion of the globe. There are several reports that trials of anti-VEGF for these cases, which usually don't work. And actually, a common clinical scenario is that some of these patients, you find them misdiagnosed early on as a myopic CDV, and they are on anti-VEGF therapy, but after a few injections, the clinician found that there's no response to anti-VEGF. So he started to think about another possibility. So far, the cause of this cuff of subretinal fluid is unknown. There are some speculation due to other factors, structural change, or changes in the choroidal circulation. But my feeling is that the exact pathology is unknown.
A question about how we can stop the progression of myopia. This is something that has been studied a lot, but do you think that there is any value of any surgery in terms of treatment of this condition, something like a macular buckle, just for the treatment of the progression?
Yeah, you mean high myopia, the progression of high myopia? Yeah, there is a lot of research going on, like pharmacological treatment or even surgical treatment. However, the early results are so far still not promising. There are also some studies about special types of glasses or some drops atropine or whatever, but so far the results are not encouraging. And surprisingly, in Asian countries, high myopia is very common. So it's very common compared. So it's affect more than almost 10% of the population in some country. So it's a very major health concern. But so far, these trials has been going for many years, and the cause for that is unknown. It's also to be some genetic disorder affecting the scleral development. But so far, most of these medical or surgical treatments are in the very early stage. And that's why my feeling is that dome-shaped macula will be a useful thing if further research done on dome-shaped maculopathy, because in dome-shaped maculopathy, you see asymmetric scleral thinning. So why the sclera thins asymmetrically? For example, if there is a posterior staphyloma, you expect a uniform thinning of the posterior staphyloma. But in these eyes, the sclera thins around the fovea much more than around the area of the fovea. It seems like the fovea is protected by a way or another by the dome-shaped change. But we hope something may show up in the future.
Yeah. Hopefully, inshallah. A question from Dr. Faisal Marek. He's asking about choroidal cavitation in peripapillary or macular area. Did you notice outer retinal ischemia or sequelae of ischemia? And how is the function of the overlying retina?
Yeah, that's a very good question. Thank you, Dr. Malik. And actually, this is a very interesting change, the peripapillary choroidal cavitation, and definitely there are some change in the circulation. As I mentioned earlier, like in this picture, sometimes they may present with an enlarged blind spot or a focal visual field defect. You can see here within the area of the cavitation, more or less, the retina is not much affected, but the area of the cavitation, in some selective cases, it may be connected to the vitreous cavity. Sorry, did I understand the question correctly? Is he asking about ischemia?
Yes, he's asking about ischemia, and also asking about the retina over on top of this cavitation.
Yeah. There aren't so much changes in the retina. For example, in this case, you can see the outer retina is preserved, but its retinal changes, my feeling, is more related to the degree of the high myopia, not the cavitation itself. The cavitation is a change that you can see. But the interesting finding in the cavitation, why they are in some cases connected to the vitreous cavity, is that the cavitation developed because some from the vitreous cavity came into the cavitation, or is the cavitation connected to the other layers? Because as you know, this cavitation here, this area is what we call the border tissue of Jacobi, and this is what we call the border tissue of Elching. And sometimes they are the same structure, but if there is a defect here, is this fluid coming from the vitreous cavity or from other source? Mm-hmm. But definitely there are some change, and careful looking at these changes, especially when analyzing that in relation to glaucoma.
A question from Dr. Asausa Noelati. She's asking about your experience of the earliest age in which dome-shaped configuration can appear, and what's the rate of progression of the condition? Can it occur in early age and be a predictor for a large myopic progression?
Yeah, thank you, doctor, for this question. It's, I think they start to appear from the age of 40 onwards. This is the most common scenario. But sometimes you see that in a younger patients, like in early 30s or even in 20s. The tricky situation is that the change in the posterior bole, as I shown in one of the slides, the different types of staphyloma. The staphyloma appears to be more complex than we thought. And the change in the axial elongation of the globe may take different shapes. This is one of the reasons why we thought to put a definition for dome-shaped macula. Dome-shaped macula was initially described by Dr. Gaucher from France. And later on, we thought to analyze these cases, to group them, we look for a macular bulge. If you look at this macular bulge, like in the slide here, more than 50 micron, and this is in the vertical scan, this is a dome-shaped macula. And in the other study, this bulge can increase. It may reach 200, 300 micron over time. Yeah, like, let me just, oh, sorry. Yeah, in this patient, you can see the bulge is very prominent here in this patient. You can see very big bulge here in that patient. And this bulge, interestingly, it increases over time. What was the second question for Dr. Sousan?
So you think it's a predictor for any a predictor for a large myopic progression in the future? if it appears in an early age?
Honestly, I don't know, but an interesting finding. Like in this slide, you can see here, there are some schitic changes here around the area, but you see in the fovea, you don't often see foveoschisis in eyes with dome-shaped macula. It seems like the dome or the bulge has more or less prevented schisis from happening, or one or the ways of another protecting the fovea. My explanation for that is that possibly the orientation of the scleral lamellae within the fovea is different compared to the parafoveal region. But unfortunately, there's no much data on the literature about the structural changes in the fovea in highly myopic eyes. But my feeling is that it's more or less related to either the structure or the orientation of the scleral fibers. They resist thinning in the fovea compared to the parafoveal region. And you can see here the sclera here is much thicker compared to these areas here in the parafoveal region.
I got a question about your recent article on foveal lucency, and I think you've described this with the work you did with Dr. Salam, if I'm not mistaken.
Yeah.
So this is a new condition. I mean, to me at least, I've never heard about it. Is this something that has any predictor for the vision overall, or is it something that is significant in terms of the anatomical closure of those holes?
No, yeah, thank you very much for the question. Yeah, foveal lucency is actually a part of the normal closure of the macular hole. So normally what we see in macular holes, the inner layers of the hole closes first, and then the outer retina closes next. And so usually you see this hyporeflective space, which is what we call foveal lucency. And we studied that in different relation of with gases. So if you use SF6 or C26 or C8, would that be different or not?
This last part was not very clear. Can you repeat just what you said about the closure? Can you repeat?
Normally, the macular holes, the inner layers closes first, and then the outer layer. And when the inner layer closes and the outer layers hasn't closed yet, you get this hyporeflective area, which is what we call foveal lucency. And we thought to study that in relation with different type of gases. Let's say if we use SF6 or C2F6 or C3F8, is there a difference if you use the gas? We didn't find a big difference for them, but it's just the way that the macular hole closes. Because, for example, if the results was in favor of one of the gases, definitely we'll try to use it. But in all, the results were similar, although we got a better or a quicker closure with the C3F8, but the difference was not that really significant in terms of the visual outcome.
Great. Thank you very much, Dr. Abdullah, for this presentation and your valuable answers for those questions that we had. I think we have come to the end of the session today.
Oh, many thanks.
I'd like to thank you all and thank all with us today for their time. Dr. Abdullah, if you want to add anything.
No, thank you everyone for joining us. It was my great pleasure to be here today. It's always great to reconnect with people, especially from Saudi Arabia and the Arab countries. My friends, my colleagues, thank you again very much for joining us today. Hope you found it useful, and I strongly recommend to start looking for these myopic changes. You will find them very common. So you may find actually most of these changes just in one eye. The paravascular changes, the dome-shaped macula, tractional retinal detachment. And it's good to be familiar with these changes, especially the vision threatening ones.
Thank you very much.
Thank you. Thank you very much.
Everyone, be safe.
Okay. Assalamu alaikum.
Alaikum assalam.